Hello, hi, good morning, good afternoon, good evening, everybody, and welcome to the webinar on internal displacement, infectious diseases, and health responses. As we know, conflict-driven internal displacement has an acute impact on the health of those who are forced to flee as internal displaced persons, IDPs. Such IDPs often face increased risk of infectious diseases, including respiratory and sexual transmitted diseases, and are particularly exposed to epidemics. The latest pandemic had some tremendous impact on these populations. And these raises important question about how health policy and providers can adequately prevent and mitigate the impact of infectious diseases in IDP populations. The Health and Internal Displacement Network, HIDN, was launched in April 2021. And through the network, we are trying to promote research engagement and evidence-driven policy on IDP health. This event, this is the second one we organized in 2021 of the HIDN webinar series, builds on earlier HIDN expert workshops with researchers and policy actors that identified IDPs as often the population the most affected by disease and death in conflict context. In this webinar, we will have the privilege of having 3 different presentations from very great panelists. 3 presentations by leading HIDN researchers who are going to present their work and their research. The first one is by Dr. Winifred Ekezie from University of Leicester, who will present and we do a presentation on essential healthcare services provided to IDPs in low and middle income countries. We then move to Professor Alfonso Rodriguez Morales from the Fundación Universitaria Autónoma de las Américas in Colombia, who is going to talk to us about the health amongst IDPs in Colombia with a strong focus on infectious and mental health diseases. And finally, we will have the chance to hear from Professor Alistair Eger from Queen Margaret University in Scotland, in Edinburgh, who is going to talk to us about health systems' response to emerging needs of IDP, with an insight from Nigeria and Syria. We will allocate 10 minutes per presenter, per panelist, and then we will have a chance to have a discussion with them, with each of them. So please do not hesitate to ask a question and use the chat function to ask questions to each of them, and we try to have a conversation with you. So without waiting anymore, I would like to give the floor to Winifred to start your presentation, and I'm going to stop sharing my screen. Winifred, the floor is yours.
Okay, thank you very much, Carl. Hi, everyone. I'll be sharing my screen now. Okay, so, okay, so like Carl mentioned, I'll be discussing on the essential healthcare services observed to have been provided to internally displaced populations. And this is based on a systematic review that was conducted in 2019. The presentation outline is as follows. I'll talk about the background, give a bit of the study details, the findings, the recommendations have been taken out, which will be done in the discussion, and some conclusions. So as we all know, IDP numbers are extremely, they're really, really high, and they're higher than refugees. As of December 2020, there are over 55 million IDPs, and the majority, 48 million, were caused by conflict and violence, and 7 million from disasters. And you can see on the right that the predominant countries affected are low middle income countries. And the picture there shows the 10 countries with the highest numbers of IDPs, from Colombia in South America all the way to Afghanistan in the Middle East, and Congo, which has over 5 million IDPs. The health challenges in displacement generally, not just for IDPs, but including refugees, are similar. They all have poor living conditions. Nearly 90% of deaths are caused by infectious diseases, mainly diarrheal and respiratory infection, HIV, and vector-borne diseases like malaria. In these same locations, they have limited access to health provision, especially against those diseases that are more common, those are communicable diseases. But beyond that, there is also a lack of data related to non-communicable diseases to effectively measure the effect of the challenges. And in those countries, the endemic diseases are also high. So they have the challenge of having several endemic diseases like malaria, coupled with the poor healthcare system before the conflict and disaster, and then being displaced compounds the challenges they face. So this review was based on an appraisal of the 8 core World Health Organization primary healthcare components, and it's assessed the evidence that have been provided since the year 2000 when the IDP global policy was adopted. But overall, we know that prevention approaches are much more effective than treatment interventions in humanitarian conditions. So all these are the basic essential services that help in prevention approaches. Okay, so the review looked out for published data from January 2020 to August 2019, focusing only on conflict IDPs in low middle income countries. 8 databases were searched, and the key criteria were health interventions, which reported quantitative outputs, and they had to be peer-reviewed articles. At the bottom there, you can see details of the main publication itself, which was published last year in the Journal of Health Promotion Perspective. The study identified over 4,000 papers, but only 13 met the inclusion criteria. In the study, we had IDPs. In the included study, there were IDPs, neighboring communities. Some studies were conducted in camps or in a clinical setting, and a selected few reported on non-IDP populations, but the numbers were really unclear, showing that there weren't strong distinctions highlighting IDPs who were not in camps. So that was one trend that was observed. The majority of the evidence that we get to see are camp-based, and showing that there's a gap in the amongst those who don't live in camps. The intervention approaches predominantly community-based and group level, with a few studies reporting on individual interventions. So this slide now shows you that the global distribution of the studies was uneven. The bulk of it were in sub-Saharan Africa, 22 studies, 7 in South Asia, and only 1 in the Middle East. That was a bit of a surprise for us when we're looking at this, but it could be because of the inclusion criteria. So the main findings for the implemented interventions, we had more treatment interventions, which are 14 of them, and prevention 11. Most of them reported the same, although we had 30 included, a few of them were reporting different and similar interventions. So the numbers may not really add up to 30 itself. So maternal child health had more, health education, immunization, food and nutrition just had 3. The types of intervention by primary healthcare components as follows. So we have surveillance, malaria control, water treatment for disease prevention, education or just education, essential drugs highlighted, medication for malaria and HIV, food and nutrition, or just 1 intervention was studied on distribution. Immunization, only 2 conditions were identified for yellow fever and cholera. Maternal and child health had more interventions on offer there, and treatment, as stated before, had more information, while water sanitation was focused mainly on water treatment. For the prevention intervention, we identified that the most common was water treatments and maternal health care, as listed earlier. And the water treatment interventions were aimed primarily at trying to reduce diarrheal diseases. Maternal health care were on antenatal care and child delivery. And we noticed that although health education and essential drugs were listed, there weren't papers reporting on them as single interventions. They were all integrated with other types of interventions. There were limited studies on nutrition, sanitation, surveillance, and immunizations. And these are the core element interventions that are actually needed for prevention of diseases that are more infectious, like diarrhea needs sanitation, health, increasing immunity needs good nutrition, issues with respiratory conditions need surveillance and immunization. So we end up seeing that there's a gap in the prevention intervention as a group. Sanitation intervention that we saw there was targeted at children, trying to increase hygiene. The surveillance intervention we saw just in one study was on early warning systems in camp. And immunization focus was trying to integrate immunization into the healthcare structure that was there, but that was a bit weak because the system was already weak. But this was a good step towards creating some sustainable approach for IDPs. So for the treatment intervention, the most common were trying to treat already infectious diseases and mental health. So TB, HIV, malaria, and the mental health conditions, anxiety and depression. I would say mental health is not really a primary healthcare intervention, but because it's a group of treatments, we classed it as a treatment intervention. The treatment challenges we noticed were most of them did not report the medication or the drugs given. They just said drugs were given, no details, no numbers. Migration affected treatments, resulting in the need for retreatments, meaning if you're on HIV treatment and IDP starts, because they have to move or migrate or are moved by the government, they end up having to restart their dose again, and that causes some setbacks in their recovery. And there was high level of non-adherence to treatment, which could be attributed to the migration and access to drugs. Malaria treatment recommendations was quite interesting because the active case finding for malaria was said to be the best way of finding cases as opposed to screening. So although cost-effective malaria control was symptom-based screening, the best approach was active case finding. So it also says that you have to understand the population you're working with and the location to know which intervention to implement. But the most comprehensive, regardless of where it was, mass approach, which is mass drug administration, mass screening, and mass treatment. So that is more comprehensive, but not always cost effective. The gaps and implications from these gaps shows that the limited range of intervention illustrates poor healthcare among conflict IDPs. I will add to that, although the study focused on conflict IDPs, this is also similar in disaster IDPs and in refugees and asylum seekers. But this study gaps is just pointing to what was found in the review. The minimal evidence-based and outcome data. So the data on coverage and effectiveness were inconsistent. Sometimes they weren't thorough, and most of the studies did not actually report who the target population were or show the sample size. So there's a bit, you can't really see how effective it was if they don't tell you the true estimates of the population. And so there's lack of evidence on non-camp dwelling IDPs, as stated earlier, showing that there are several IDPs that are unreached and hidden and sometimes classified as invisible IDPs. So those populations need to be paid attention to because there are actually more of them than those in camps. Limited prevention resources and intervention make infectious disease mitigation difficult, especially considering the current pandemic we have with COVID-19, where it's hand, face, space, wash your hands, keep 2 meters apart. When it's overcrowding and no good living conditions, that's a bit difficult to do. So the limitations from the exact study were it's focused only on English language articles and quantitative data. We used gray literature. We did not consider great literature because of the lack of methodological evidence. So in as much as we may have organizations, NGOs, government in providing interventions, if this is not in a peer-reviewed literature, we didn't quite catch it. And we tried looking at it, but there was just so many of them and inconsistent. There was a wide variation in indicator measurements, as I stated earlier. So the epidemiological evidence were a bit hard to do a comparative analysis across different parameters. So in conclusion, a variety of intervention programs can be implemented. We've seen that is possible. Irrespective of the program package, it can be effective and beneficial. And if it's integrated and the prevention and active case finding intervention, those are the most cost effective. Then finally, more publications need to be done to encourage implementation science in humanitarian settings. This is because if we don't know what has already worked, it's a bit challenging to know how to design future interventions. So that brings me to the end of my presentation. I will stop sharing my slide now and pass over to Carl.
Excellent. Thank you very much, Winifred. It's fascinating and so great you've done this work. So, Alfonso, if you want to put your slide up, that would be fine while I have a very short conversation with Winifred. I'm so fascinating to see how little evidence there is. And it's so great that you have used health outcomes. And I'm sure that Bayard Roberts have some memories about these kind of systematic reviews, and it brings some good memories. Alfonso, the floor is yours, and I will come back to you, Winifred, for the questions. I've got a few for you at the end. Alfonso.
Thank you very much. Thank you very much for the invitation. I will address specifically about health among IDPs here in Colombia, the focus in infectious and mental diseases, and some experience regarding this here in the country. I will address this point. I will talk quickly about the general recent and current situation of Colombia regarding IDPs. I will talk about some diseases and some mental condition among IDPs and some conclusions about this situation. Well, certainly the case of Colombia is very interesting, and talking about this situation is interesting from the point of view that Colombia is a particular country in the region, in the Americas, in Latin America, regarding IDPs. As you know from data from the United Nations High Commissioner for Refugees, 1% of humanity is displaced, and these include not only a refugee population, but specifically a displaced population. And among these figures related to internally displaced population, Colombia is highlighted in some statistic as the second country among the top 20 countries with the largest stock of internally displaced persons by conflict and violence, in this case by 2018. And particularly in Colombia, we have a very mixed situation, especially right now, which is important to consider for different purposes, where we have 7.4 million IDPs for 2017. But in addition to IDPs, we also have refugees from Colombia to Venezuela, to Ecuador, to Peru, to Panama, and to other countries, as you can see here in these red balloons or pink balloons. But in addition to that, and this is another point that should be highlighted, we have another problem that especially over the last years, we have also refugees from Venezuela, given the situation in Venezuela. And this is a mixed situation where Colombia received population from Venezuela, but also is a place where people from Venezuela initially migrate to in order to move later to other countries such as Panama, Ecuador, Peru, and many others. And this has multiple implications for health and especially infectious diseases. But very quickly on this, the origins of the conflict in Colombia are located in the middle of the last century, and we had decades of conflicts with multiple, as you can see, armed groups that fortunately over the last years, especially in the last 10 years, have significantly decreased, and especially after 2012, we have the agreements of peace that began and that were signed in 2016, where the major group of guerrillas, the FARC, the armed group in the country was fortunately leaving the arms, and this began a different stage for the country. But as I mentioned, right now, and especially over the last 3-4 years, also the situation from Venezuela has been very highlighted for the multiple implications that this forced migration from Venezuela to Colombia also impact in the situation of Colombia. One particular interesting point is that over the last year, especially the last decade, there has been an increased number of assessment brigades, missions, medical groups, and research groups that have been helping and assessing the health situation in different areas of displacement. And with that, we have access to data that is interesting to show the wide spectrum of diseases that are affecting internally displaced populations in Colombia. And we may discuss some of these selected infectious diseases by different groups, such as has been the case already mentioned in the previous presentation of the importance of vector-borne diseases. And we may say here that especially we only not have just malaria, but also it's important leishmaniasis, and this disease that is a Latin American disease, the transmission is a disease, Chagas disease, caused also by a parasite. And in addition to that, we have also arboviral diseases, the viral diseases that are transmitted by mosquitoes, such as is the case of dengue, chikungunya, and Zika, that have been especially the last two important over the last 5 years. And we have also important among these groups respiratory infectious diseases, such as is the case of tuberculosis, which is highly prevalent in Latin America in general terms. But as I will show, especially now we are looking this on IDPs, influenza, and a wide spectrum of gastrointestinal infectious diseases such as Ellman diseases, ascariasis, and other soil-transmitted ailments, giardiasis, bacterial gastroenteritis, and as has been already mentioned, also sexually transmitted infections such as HIV, syphilis, among others. Some recent studies that we have performed in this way have shown that, for example, in the case of malaria, when we compare the specific and just incidence of malaria among IDPs, we found that IDPs have a 4 times higher incidence of malaria when we compare specifically by years, by territories, by states of or departments with the general population, but also the mortality among them by malaria is also close to 6 times higher. Some of the parasites that cause malaria, such as Plasmodium malaria, are really higher among them. And this is also related, as many experts in malaria know, that this is a species very related to lack of vector control in certain special selvatic areas. And you can see here that the incidence of this parasite, which is not the most common as the case of Falciparum vivax in Latin America, we don't have ovale here, is almost 7 times higher among IDPs. In the case of leishmaniasis, another parasitic vector-borne disease, some recent studies have also found a similar situation where you can see that leishmaniasis was 4.5 times higher among them when compared with a general population. But in some specific areas where leishmaniasis is highly endemic, they are even more affected than general populations, such as is the case, for example, in the Coast Triangle region with the Department of Caldas, where the incidence of leishmaniasis was 132.7 times higher among IDPs than a general population. Leishmaniasis is not only here a cutaneous disease group or diseases, but also visceral leishmaniasis, and these also occur among IDPs children. With other vector-borne diseases, such as the case of dengue, chikungunya, Zika, so the incidence is not significantly higher among IDPs, is reported also among them, and they are also then affected by diseases such as dengue, chikungunya, and Zika. In the case, for example, of ascariasis and tuberculosis, in these studies, we have found also that the incidence among IDPs is 5 times higher for ascariasis, a soil transmitted helminth, but also 8 times higher for the case of tuberculosis. And if you see here the trends in time for this study period, you will see that the incidence among IDPs was in general terms higher over the time and higher in different departments of Colombia. A similar situation you can see here with the case of tuberculosis, which is not only for the case of pulmonary tuberculosis, but different extrapulmonary forms of tuberculosis, which are important. Let's see, for example, bone tuberculosis, central nervous system tuberculosis that were higher among IDPs than in general population when were adjusted and compared. Finally, from infectious diseases, it's also important to mention sexually transmitted infections. Some data suggests that, in fact, here in Colombia, HIV is higher among displaced population, and even also the vulnerability to infectious diseases, and particularly to HIV and other sexually transmitted infections, is considered higher for IDPs. And some studies have found for syphilis that this is also a present situation among IDPs. To end in addition to infectious diseases, another interesting group of diseases that we have assessed here in Colombia are mental health conditions, and post-traumatic stress disorder among IDPs have been found 5 times higher than compared with its incidence among general population of Colombia, being higher in some regions of the country, which is another point that we should consider when we make these comparisons. We also need to look at the specific difference by years and in different areas where this can be higher. For example, another condition, alcoholism, is also found higher among IDPs, as you can see here, ranking from 1.8 times higher to even 3.2 times higher. But again, in some territories, this incidence is higher among IDPs and higher than in general terms about this comparison. And you can see here, these are the rates review that show that in some areas, this difference showing that the occurrence of these mental alterations is even higher in some areas, and the same for some age group, as you can see here. Depression and anxiety also have been found higher when compared with general populations and situation. If you look on different territories in Colombia, you will see that this is significantly higher among IDPs when you compare with general population. And as expected in areas where in general terms, some mental health alterations are quite more prevalent. Also, we found that among IDP, there is a trend for higher occurrence and the same situation of higher incidence and prevalence among IDPs when compared with general population. And in the case of depression and anxiety, this difference was 2 times higher on IDPs when compared to general population. To conclude this presentation, as evidence in our recent experience and from other research groups, in the case of infectious diseases, especially tropical diseases, are significantly higher among IDPs. Other of these infectious diseases should be specifically addressed in more detail. Sexually transmitted infections may be also higher, especially in the case of HIV. And mental health, as suspected, is significantly affected, and different studies show a higher incidence and prevalence of different conditions, as I mentioned. Then, further studies in this context are deserved here in Colombia, and of course, enhanced surveillance, preventive strategies, and interventions have been deployed and need to be still worked in the near future to improve this situation in the country. Thank you very much for your attention.
Thank you very much, Alfonso. And you've been such a lead researcher in this field. It's so enlightening to see population group comparisons. Very, very, very interesting. Thank you so much for all your work and all the evidence you have generated. Excellent. Alistair, you can be ready on your slide. I will invite Alfonso and Winifred to check the chat. There are quite a few questions for you. Alistair, the floor is yours.
Thanks very much. Can I just check, Carl, can you see that clearly?
Yeah, we can see 2 slides at the moment. It's on lecture mode, I think. So you need to put on slide. Yeah, it should be better. Is it? No, it's black at the moment.
Yeah, let me try one more. Sorry about this, guys. I think we're trying to do, sorry folks. Let me try one of the things, just 1 second. Let me share another way. What about that now, Carl? Is that any better?
Well, we can see the 2 slides, but I think it's
okay,
big enough.
With that. I don't want to hold you up.
Yeah.
So thanks ever so much. Here's the opportunity to talk a little bit beyond now the needs of IDPs to talking a little bit about health system response to IDP needs. And I want to just focus on 2 studies, 2 case studies. You can see one from Nigeria and one from Syria. Let me take you to the first paper, which is looking at the resilience of the health system in Yobe State in particular. This study is around 5 or 6 years old, was at the height of the Boko Haram insurgency and the counterinsurgency. And that's an important point, I think, in terms of thinking of the disruption, not just due to rebel activity, but also counterinsurgency activity in states within Nigeria, which significantly disrupted community life, including the provision of health services. And in both of these papers, I want to talk a little bit about a methodology that we've used to try to understand the dynamics of the health system, of how the health system is challenged by conflict leading to displacement of populations, how it responds to that, and what strategies it might use. So I will go fairly quickly through the methodology, but for those of you, this is Yobe State in the bottom left-hand corner, the map of Nigeria, Yobe up in the northeast, and the map above it shows the local government areas of Yobe State, and that will be seen as interesting in a moment because the internal displacement was partly from Yobe State to other states, but particularly within the state from one LGA area to another. And we're able to map something of the movement of the population and the disruption of the population within the state as well as across the state. The image on the left in terms of roadblocks and military activity is something of the significant disruption of travel and insecurity that was at the height of the insurgency and counterinsurgency. And so the images on the right are then talking about, well, how did we interact with the health system? How do we understand their challenges and their responses? So the top right is reflecting, we did interviews with the members of staff, both clinical officers, health planners, nurses, also clerks at clinics and some community mobilizers. So working at various layers of the health system. To be honest, that the questions are fairly straightforward. We would talk about their role and their provision of service. We would talk about the challenges that have been brought around through the movement of populations and the conflict. And then we would talk about the adjustment in their role, either individually or as a group, that had resulted from this. And this gave us a really vivid set of qualitative data which enable us to identify key variables, key factors that seemed to influence both the needs of IDPs and the capability of the health system to respond to them. So the middle image there is members of our local research team beginning to consolidate some of those findings into key factors, key variables, and begin to prepare for what's called a group model building session, which is what's depicted on the bottom right of that first slide, of the slide to the left for you, which is bringing a few representatives of the health system together to talk through the crisis, to talk through their response, to talk through the shock of the displacement, but also to talk through the response of it, and try to build a model which reflected the decisions and the factors that shaped experience over that time. Now, this won't be very clear for you, but one of the methods that we use is a thing called rich pictures. If you look very closely to your screen, you might see that this is of a form of a triptych, 2011 in the bottom on the left, 2012, 2013 in the middle, 2014 on the right. And we're getting the group here quite deliberately out of just the mode of using a flip chart to depict the images and the reflections on the conflict. And basically this was an idea, 2011 was at the early stages of the conflict and displacement. 2012, 2013 was the height of it, and 2014 was then in a state of some consolidation and resolution. And these sort of images are quite important to us because they often facilitate health workers sharing little bits of detail. You might see a church roof on fire on the left-hand side, and you might then see a mosque roof on fire in the middle, of showing how the spread of the conflict affected different populations and led to different movements of peoples. You'll see various arrows of people moving in and out of villages, and you'll see some responses in terms of the lines, the queues outside of hospitals, and how some clinics were deserted and others were overwhelmed. So it's beginning not to give us literally a rich picture of the experience in this environment, but also helping us to get an understanding of some of the factors that underlie and help us explain that response. We're also then able to triangulate that qualitative data against some more quantitative data. And here are 3 local government areas, and the facility attendances is the upper figure. And the thing that you should just see from this is the huge variation from quarter to quarter. And this is reflecting populations moving from one LGA to another as Boko Haram attacked sometimes urban centers and led people to flee to rural areas, at other times attacking rural areas and leading people to come to the urban center in Damataru. And on the lower figure, this is actually on deliveries in clinics. You'll see an even stronger cyclical pattern of very high levels of utilization one quarter, very low levels another quarter. And that's partly a result of clinics being open or shut, but that's also linked to the demands from internal displaced populations in that area. So the system is having to respond to huge surges in demand and huge barriers to service delivery. And so what we're trying to do in terms of this group model building is to build a picture, and this is the main picture that emerges from that. It's a somewhat complicated one. I'm going to try and simplify it in just a moment. But basically, these are the issues, the key facts that health workers ended up talking about, and the arrows result from fairly intensive discussion and modeling with the teams about asking, if I pick something like utilization of health services in the middle, when did that increase and when did it decrease? What were the things that facilitated it? What were the things that eroded that? And beginning to identify some of these potential causal linkages, some of them stronger than others, but basically this is a hypothesis from the team, or their best description of the dynamics of the system as they worked within it. And then I'll do a slightly different thing for the second study, but for this study, basically then trying to identify key pathways. So you should hopefully now see blue lines, which is essentially the displacement of populations. So insecurity leads to the migration of persons within the state. There are movement difficulty restrictions which reduce access to health facilities, but other people move so that they are closer to health facilities. That generally either leads to an increase or a decrease in the utilization of health services, often creating a pressure on certain health infrastructure, and a general view that that led to a decrement in the quality of healthcare that could be provided when there were long queues outside of clinics. That's all in terms of the demand side, but on the supply side, there's also a huge dynamic that operating on the health workers themselves, so that insecurity led to fear and anxiety amongst health workers and the exit of a number of services and programs, restrictions in technical support and HR capacities around the left-hand side. So that's the supervision and support and project engagement in the state gradually eroded. But much more generally, there's a migration of health workers, which reduces HR availability and further increased health worker workload for those that were still resident in the area and still working in the area. And in that turn, again, reducing healthcare quality. So we see two key dynamics through migration. One, the migration of populations leading to inequitable load within the existing health infrastructure, but we also see that migration also affecting health workers themselves and their supervision and their technical support structure, all leading to a potential erosion of healthcare quality. But that was only half of the question that we're asking, because we're not just asking people to describe what were the shocks and the challenges. We're asking them to account for the responses and the pathways of resilience and response. One key one here marked in red, sort of driven from what we call political will and financial support, was that the Yorubayan governor and political elite saw this was a critical time to strengthen certain aspects of the system. There had been a freeze on HR recruitment that was released, HR availability improved. There was increased liaison with security. I had said that initially Nigerian Defence Force presence was very suspicious of, often from Nigerian soldiers from the south, suspicious of native Yorubians, and caused significant disruption of much travel of all Yorubian staff, including health workers. And health workers then were issued with passes and given greater security benefits in terms of being able to negotiate roadblocks, etc. And there's a pre-protection element that the political will and financial support had initiated a free drug program, which actually enabled the delivery and stocking of pharmacies, which would have been significantly more of a challenge if that hadn't been a measure put in place previously. Another key pathway, which we get familiar, marked in pinky purple here, is it wasn't just a political response that was strengthening recruitment, including actually coverage of insurance and death benefits for Urbane staff that would return to work in the state, but it was also community engagement and community cohesion. The most vivid one was community members accompanying vehicles as emergency ambulances to clinics which had previously been victim of Boko Haram attacks. So official ambulances were often seen as very vulnerable. So significant community mobilization to support travel to otherwise inaccessible health facilities. So this is just trying to give an image, partly of a methodology, but crucially for me, in terms of response, that this isn't just a list of the challenges that the health system saw, but it's a list of the way that it moves and mobilizes resources to be able to address some of those challenges and improve quality of care or service availability. And a final little loop, which you might just see the lower half is in orange, is staff motivation and commitment. And that was very evident. We'll also see in the second case study with Palestinian workers that although many non-Urbane staff left the state, many Urbane staff stayed. And indeed, many Urbane staff returned from other parts of the country to support their state, which was in a parlous state. Shift patterns were changed, very strong evidence of task shifting and burden sharing, which would, under other circumstances would have been particularly challenging, but in the context of this emergency leading to significant internal displacement, major response. So that's my first case study. I want to go through similarly quickly a second. Sorry, just this slide is in terms of abstracting from a number of studies. I don't want to spend too much time on this, but some idea of what are the sort of common patterns that we see in some of those early studies that we did. And one is what we call collateral pathways, more than one way of doing something, achieving something, using different workers, other supply lines. When you're under pressure, having a clear focus on either a particular disease or a particular form of service delivery, having some form of storage capacity, and that might be drug stocks, crucially important, but it might be also other ways of which a capacity is retained through a difficult time. And this final point linked to the political will and community cohesion, acknowledgement under severe pressure, although there is huge stress of the social fabric, there's also a sense to which a conflict may be an opportunity to realign motivational interests. And many nurses and doctors told us that they were working more closely together with colleagues during the conflict than they had at any other time when their professional disciplinary differences were often more in play. Right, very briefly, Carla, I will go quickly. A second case study, you'll see some similar patterns, but in this instance, looking at internal displacement within Syria, and particularly the displacement of Palestinian refugees, Palestine refugees registered in Syria, which before the Syria conflict were in large numbers of places of the country, including a number of Palestinian camps, Yarmouk being the most famous one of these. But during the conflict, significant challenge to provide services to these areas. And as we all know, significant bombardment and conflict within these areas led to displacement outside of the country. And we've also seen Palestine refugees from Syria moving to Lebanon and to Jordan, but significant challenges provision within the country itself. And this is a brief report on that work. You might now see a bit of similarity of these figures. So the top left-hand corner is we're talking to doctors, clinical officers, nurses, clerks about their experience of providing services to displaced populations. The middle picture on the top right is this idea of the triptych again, talking about how have things changed over, in this case, 2010, 2013, 2017. Let's describe something about to try and identify the dynamics. An exercise we use quite a lot is in terms of this sort of timeline and trying to identify this cases the flows of refugees or displaced persons, also the level of the conflict, and you'll see a work on the left-hand side, giving a vivid account of this is when it changed. Well, 2016 was okay, but then going into 2017, this was the problem. And it's that discussion of the changes that made a difference and how those changes were linked together that encourages us to build towards what's happening in that bottom right-hand diagram, which is those factors. Then the team, with a modeler, I'm not an expert on Syria, I'm helping this team tell us the story of how they adjusted things, what the shocks were, how it affected their provision of services, and how they responded and the barriers to that response. So again, no surprise, I'm going to take you to a complicated diagram. The aim of these diagrams is not just to be complicated, and clearly we often need to focus an area of this, but essentially this is the account that the health teams gave from UNRWA Syria about, you can basically see the conflict on the left-hand side and the ripple effects of insecurity and displacement. But as you move to the right-hand side, we've been to see that's not just affecting the population, but it's affecting the capacity of the system to respond, whether that's availability of fuel or availability of transport or availability of staffing. So that's giving us a picture of the dynamics that they're having to manage. That's really all that the diagrams of threat and difficulty. I want to take you on to a second diagram, which I'm going to hone in on, which then most of that diagram left-hand corner is what you saw on the previous slide, but now we've got yellow, green and purple lines, which is how the service is responding to that. It doesn't just passively receive those shocks, it adjusts variables, it moves staff around, it closes one clinic, it opens another clinic, it gets drugs from another place, it redeploys staff, it changes redeployment policy. And so on the right-hand side, you see lots of arrows flowing back, which is basically the responsiveness of the health system. And there's really just two conceptual points I want to make before I close. So we and Carl and Bayard have done similar work in this area. One of the framings that we've tried to use in terms of understanding this resilience is to understand some form of resilience which could be seen as absorption, and that little orange loop around staff pressure and task shifting could be seen partly in relation to that, which is that you have developed things such that people can take the pressure, you know, that you don't change anything, but you've built up some capacity and some strength so people can absorb a degree of shock, a degree of challenge. But you'll see that most of the adjustments here is not absorption, it's what we would call adaptation. Those green lines are changes, they're decisions, they're moving resources around in a very active way. And I think this is a very vivid picture of how active management of a health emergency and meeting the needs of displaced population involves many, many judgments, and you can follow individual lines around if you're interested, whether it's reimbursement or whether it's clinical protocols or whether it's drug supply. And then there are a few things there in purple, which we'd call a transformational nature of response, which is not just adapting the service, but really changing the whole way that it operates, doing completely new things in the space of a new situation. And that's just a slightly larger size font, so you can see some of the innovations, for example, about developing MHPSS services, which was completely new, essentially, to UNRWA at that time. Final two slides. So just in terms of that those definitions, then that idea of those three elements of resilience is gaining some visibility, and we think it's accessible to policymakers and staff members. It makes sense to them that there's something they can do to help them absorb tough times. There's something they need to do about improving decision making to adapt, but there's also something about doing some things in new ways that is important. So it's a useful framing. Then my final figure is there's another way of using these causal loop diagrams, which is the maps of that, which is to look, this is just a subsection of that loop. And it's to look at what's called balancing loops. So essentially, these are pictures of the dynamic. And I'm hinting by the way I speak that there's a shock, there's a demand, but then there's a response from the health system which tries to balance that and either reduce waiting times or restore the quality of service. So we're looking for forces that result in balancing. And if you look for these circles of arrows that actually make a loop, then you suggest that there is actually a balancing process there. And here we've got 3 balancing loops, one around accessibility, one around the deployment of staff, one around links to other services, that's B3, B1 and B2. But the key point I wanted to make is in the midst of driving all that, we've got that clinic area and field office decision making. And what was very profound in this particular case study was that there was strong decision making, moving resources around, committing to things, yes, from UNRWA HQ back in Amman, but also in Damascus, and also at the local area. And that capability to make local decisions as well as higher level decisions was seen as absolutely key in enabling an adaptive response to the crisis. Thanks ever so much, Carl.
Thank you very much, Alistair. That's fascinating and very interesting work. And I'm so glad we have 3 different presentations looking at different aspects of IDPs and health. So it's fascinating. So there are quite a few questions in the chat, but please do add a few more, and I will try to keep an eye on that. But I've got, for Winifred, I've got quite a few already on my list. And there's one question from David asking you about what do you think are the key priority areas for health research? Now you look at all the evidence, and you have identified quite a few gaps, and you have in front of you a group of researchers who are very keen to work on to invest time, and so what kind of advice would you give us?
Okay, thank you for the question. I am biased to say that Alistair has given it away already. I was going to say anything that has to do with sustainability of an intervention. We can pick up one particular challenge to focus on, but because it's a myriad of challenges, the bottom line is how can we sustain what's already been implemented, which will be emphasizing the health system arm of it. And Alistair's fantastic causal loop shows you different ways we can address it. So for the health research, I would say trying to find a way to sustain what is being being done with the scarcity of resources. Is how do we utilize what we have and stretch it as far as possible. One other thing we can do with that is using community involvement. That's one way of sustaining it. So the health research, as one way of addressing the health conditions, is how do we implement in each intervention ways we can sustain the services being provided.
So you're telling us, okay, please look at implementation research and implementation evaluation. Is it what you mean?
Yes, that can be it, yes. But also, how can that be sustained? So for example, if an intervention being provided, most of them will be provided by NGOs. But what happens when you leave? Do you have a section where the people can actually continue? Is there a continuity plan? You can put it that way. A continuity plan, a sustainability plan, a plan that the people can actually keep doing what was being done, albeit in a very minimal way, but something that can continue, as opposed to when it's done and the agencies leave, it's back to the beginning, it's back to square one, where nothing is being provided anymore because there's no way to keep it up.
In your presentation, Winifred, you highlighted the lack of evidence or the lack of studies in the Middle East. How do you explain that? Is it the quality of the studies that were not good enough and were not selected, or because I mean Iraq and Syria, Alistair talked about. I mean, these are the countries where we have high numbers.
Yeah, that's I was also surprised by that. But after going back again, the initial search for this study was done in 2018. Then I found nothing in the Middle East. That was a shock. When it was updated in 2019, I found one. So it shows that with time, more studies are coming up and are being published. Secondly, the review focused on peer-reviewed literature. So you could say most of the evidence might likely be related to they're being reported as reports by agency reports, organizational reports, and maybe in Arabic, because most of the information there would likely be in Arabic. So because we focus only on English, we may have missed quite a bit. But I would say I'm sure if that search is run again now, there'll be more studies, but overall, I went through a few recent similar reviews and similar gaps were there. The studies on the Middle East are not as many as those in Africa or in other areas. It could be the language, it could be the reporting domain. So.
Excellent. Thank you, Winifred. Please, the panelists, I invite you to step in at some point if you want to ask a question or make a comment during this discussion. Alfonso, we have quite a few questions about the differences and explaining the differences between these different groups. Some of the assumptions we have are linked to the housing and living conditions of populations, but these cannot explain everything. I mean, what kind of explanations do you have? There's so many differences, not only in terms of infectious diseases, but as well, you highlighted as well PTSD. So, I mean, did you research that, investigate that?
Yeah, certainly. You have to remember that from the point of view, especially of these infectious diseases, these tropical diseases, these are multifactorial conditions and are not only health conditions itself, but even more social conditions. And this is also related to social and to environmental aspect. I should highlight especially the location of the most affected people are precisely the areas where there are ecological prone conditions for transmission, vector, animal reservoirs in some zoonotic diseases. So in general terms, this location coupled with these other factors, education, the lack of access to healthcare, early diagnosis, early treatment, these are or conditioning this situation, for example, for the case of these tropical diseases, such as malaria, leishmaniasis, among others that even still need to be more studied and defining in comparison between these populations. But in the case of mental health, this is very related, in fact, to the origin of the displacement, which is the conflict. This is an armed conflict where people were forced to move to different areas without their things, leaving behind families, leaving behind many things. And this is beginning a traumatic condition that is related to multiple situations, people losing their relatives, people that were forced even to participate in the conflict army, to integrate to guerrillas and to the paramilitary arm. So it's also multifactorial, and it depends, as some of the questions were asked, also to pre-displacement conditions, but also the causes of the displacement, and certainly what happened in the places where this population is displaced. Stigma, discrimination, and many other adverse conditions at the places where they finally were displaced are also factors to be considered in situation.
Yes, Alistair.
No, I just wanted to ask Alfonso, are there legal barriers to access, or is it economic barriers, or you're hinting at sort of cultural barriers in terms of being internally displaced, so having a right to services, but from what you're saying, then clearly significant barriers to actually receiving them? Yeah,
I like that question because it's important to highlight that many of the populations are in remote areas. It's a problem that is related to different factors, beginning that when the conflict is active, there was no access to healthcare because the health services are not provided in such areas, in areas that were controlled, extensive areas that were controlled, for example, for guerrillas and for other paramilitary groups. And so people located in those areas, even not participated directly in the conflict, were also affected because of this lack of access to the healthcare. It's not an economic barrier itself, but instead of that, the problem itself caused by the conflict. And then when these populations were displaced, also related to the problem of being located in areas, rural areas, in most cases, without access. In those cases, from IDPs that were located in urban areas where these conflicts were not present, also they were among the most vulnerable classification for the health system. These people were in a special social security system, which is highly vulnerable because has the preferential access to all the possibilities in the healthcare services.
Thank you very much. Have you seen, Alfonso, last question, and then I'm going to talk to Alistair. Have you seen such adaptations in your health system? 7 million displaced people going from one region or one department to another. So what happened in terms of health service delivery? Have you seen the adaptations or transformation Alistair was talking about?
Yeah, right now, and this should be recognized to the Ministry of Health of Colombia over the time, has considered the importance to have this as a special population in multiple ways, in terms of surveillance, in ways of consider the associated risk, vulnerability as a special population. And in fact, in all the whole system in the country, if someone is displaced and is considered displaced, should be notified and should be managed as a displaced person. And that's the reason we have, in fact, data and access to make such kind of wide assessment of the situation in the country. And certainly, enhanced surveillance for this population in certain areas is acted as well. Different programs that are especially oriented to this displaced population among the healthcare services.
Thank you very much, Alfonso. Thank you very much. We come back to you. Alistair, yes, we've seen these visuals. They are very powerful and very, how do you say that? Illustrative, because they're easy to understand. Have you presented this work to policymakers and providers, and what kind of effect did you have on them and in terms of decisions?
So yes, and I suppose at different levels of service providers and policymakers. One way of answering the question, Carl, is there's a sort of a tension within that method, I think, and it's reflecting some of the questions. One is about telling a story and almost giving a space for people to give an account for how they coped and what they did, a very qualitative method, and to sensitize people to issues. Another is a more quantitative, predictive one. And at the outset, we've tried to do a little bit of each. I have to say we're probably more successful with the former, so that the teams, when we fed this model back to them or shared with them, I have to say they felt valued, that they felt this was their story, and there was a sense to which acknowledging it and sometimes recognizing interdependencies that had not been apparent at the time. You know, we had that problem and we now understand that you couldn't do that for us because this problem was happening. So there's a sense to which it's useful in terms of dialogue and explaining. I have to say, I have enough of a quantitative scientist in me. I would love to use it as a predictor. One of the ambitions is to have this as a simulation and to say, well, let's actually increase the or let's reduce the number of nurses by 50%. Let's increase the distance to the clinic by this and work out what the implications of that would be. And the nearest, in Yobe, we just didn't have the data to run those simulations. With UNRWA, we potentially do, but what we're actually likely to do is to actually run the model basically based on data from around 2014 to 2017-18, and then test the model on the data we have from 2018 to 2021, which would be the clever thing to do. So we're still in the midst of doing some of that. The final comment is that one of the senior, Dr. Akira Saita at UNRWA, very much value this work, but he calls it spaghetti. And I'm pleased you say it's clear, because one of the things is it's complicated, and often policymakers, and I've been working with them, we differed quite a lot recently, want a simple answer, and to say, well, there's so many variables is not always what one wants. But I think one of the things the models have been helpful with is steering people to key points of leverage. There's maybe many things you can't change in that, but where are the few points that you could make a difference? And that, just to comment on something Winifred said, I think one of the things from Boko Haram Yobe scenario is that you lost a lot of providers very quickly early on, and the state services were really left holding quite a burden, and you could have anticipated that and strengthened the core service provision when NGO providers and international providers were pushed out of the state.
Thank you, Alistair. There is an interesting comment from Suda. And Suda, if you don't mind, I would like to give you, you can unmute yourself and talk about your example from Kashmir. I would like to hear from it, about it. If you agree to talk.
Yes, I can talk, but I cannot start the video. Let me see.
Okay, no problem. Shall I give you a couple of minutes and you explain a little bit how that relates to Kashmir?
Absolutely, absolutely. But can I make myself visible also? I think the video is not active.
No, I think it's not active. Sorry for that.
Okay, no problem. All right. So I did a research on conflict-induced displaced Kashmiri families which were displaced due to militancy in 1989. In the India-administered portion of Kashmir, not the Pakistan portion of Kashmir. So about 250,000 people were displaced due to militancy, which took over the Kashmir Valley. And so after 1989, they were moved around to various parts of India, and they remain IDPs, absolutely, because none of them chose to actually cross the border to where? To Pakistan or Bangladesh. No, they remained in India. So my doctoral studies investigated the plight and the policy making that was involved. So a number of IDP families that I interviewed, they explained that because those who were displaced were not poor people. They were the high caste, high class of Hindu families. They were doctors, nurses, poets, teachers, and so on. So, of course, they were not required to work or anything. They were given subsidies by the Indian government. So they had plenty of time to volunteer their services to the local communities, for example, by teaching. They also helped build clinics, medical clinics, and they brought a lot of know-how from the work that they had been doing. So in fact, when I interviewed the hospital staff in Jammu and in Delhi, they told us that thank God that we had received as many Kashmiri families as we did, because they have actually boosted our know-how. We actually are working better in Delhi and in Jammu. And the same response was from the teachers that I interviewed, the principals of elementary school teachers. They said, thank God for these Kashmiri children, because they really study very hard. They are bookish, they like to study. And our children actually are doing much better ever since the Kashmiri people came to our communities. So in this respect, because the Kashmiri Pandits were given subsidies from the Indian government, so they were not really looking for a job. They were not really, but they really were in a need to share their know-how of medical facilities, of how they used to work in Kashmir, and so on. So this was a very interesting insight that I got from having talked to so many displaced families that are residing in various parts of India, Jammu, Kashmir, Srinagar, and Delhi, and so on. So this is what I wanted to comment to Professor Alastair.
Thank you very much for that. That's very, very fascinating, very, very interesting. Thank you.
Carl, can I just pick up one point from
Sure.
very briefly? And it was implicit in both Nigeria and Syria, but it is that what is the bounds of the health system? Health system response, we might just think about doctors, nurses, clinics, and so on. But when we tell the story, we have to go to those community resources that helped escort the ambulances and so on, or helped secure the drugs. And it's the sort of thing that Sudhir's talking about. And we had to talk about political powers, and the state officials in Nigeria didn't just act with political will independently. They were being lobbied very actively by communities in terms of falling population. So it's a very social political process, as I'm saying, and I think it shows that the response to the health needs to engage community actors and political actors in a powerful way. And thanks, Sudhir, for that illustration.
Thank you very much. I'm just going to give you the floor for the final word, Winifred, Alfonso, and Alastair. Before I do that, I just remind you about the third webinar, which is going to be on mental health amongst IDPs. That's going to be on Wednesday, the 7th of July at 3:30 BST. And we're going to have a few examples from Ethiopia, Colombia, Georgia, and Ukraine. And so the registration link will be on the website, on the Internal Development Research Program website. So we'll post that on the chat as well. But final word from Winifred.
What I'll say in respect of my study and from the other presenters is we need to emphasize on evidence reporting, because if we don't know what is being done, we don't know what to do later. Like the case study of Kashmir. Evidence like that is very important, so we know how to strengthen what can be done later. Secondly, for every intervention or services being provided, let's think long-term and think beyond just the service. So sustaining it and continuing the intervention being provided. And we need to engage the communities, because they are the ones that benefit from it, and they're the ones who can actually help make it more effective. And it's also good because they feel they belong and they can associate with what is being provided, and that's a way of getting them to adapt back into the community as well. Thank you.
Thank you, Winifred. Thank you very much, Alfonso.
Well, I would like to say that first, thanks to the network, and thanks for the organizers and the colleagues in this presentation. I think these presentations are especially important to highlight the situation, to make visible these things that usually even in specialized settings are not even in discussion. And in the case of Colombia with IDPs, there is still a long road to be visit, develop, and work in different aspects related to the health of IDPs, included not only, of course, communicable, but also non-communicable diseases. And it's good to promote the information through these activities. Thank you very much.
Thank you very much, Alonso. Alastair?
Well, thanks so much, Carl, for convening, and it was delightful to follow Winifred and Alfonso so clearly depicting the burden associated with internal displacement on those populations. I suppose my hope is that that those present have a sense. I suppose one image would be the arrow from my presentation. The arrow suggests there's some action and there's some adjustment. So if there are those increasing burdens, then systems need to adapt to them, be aware of them. And those adjustments may be at Ministry of Health level, but it may be at the clinic level, or even just the way a nurse or a clerk registers a patient. There's so many little adjustments that can be made that can address those. And I think the dynamics of change in response to changing needs is the key message I'd want to reinforce. And delighted for the opportunity to share it through the Hidden Network.
Excellent. I think it was an excellent conversation about what is going on, and it's so rich in various parts of the world. Thanks to you. So thank you very much for your work, and thank you for sharing that with us. So there will be the third webinar, as well as a complement to the network. We are launching next week the Lancet Migration European Hub. There's an equivalent one, Alfonso, for Latin America. I can connect you with the people if you're not aware of that. And we hope that the Lancet Migration Hub as well is going to support HIDN, and you can count on me to be his ambassador. I would like to really thank Gina Schwartz, David Cantor, and Bayat Roberts, who are very much a driving force behind the HIDN. They are the ones who have brought us together to make sense of all the work and trying to make sure that we are going to work together. Thank you. So thank you very much to the three of you. And we're going to stay connected through the HIDN, and hopefully we're going to collaborate. So thank you very much.
Thanks all. Thanks, Carl.
Carl.
Thank you, Alistair. Thank you, Winifred. Thank you, Alfonso.